I'd like to talk about each step of my cataract surgery. Last year, in 2018, I operated 8,600 cataracts. Among them, 11.9% are multifocal and 43% of the cases are toric. I ruptured the posterior capsule in 15 cases, no endophthalmitis for 20 years. First, I'd like to show my operating theater. I usually operate 60 to 65 cases a day. I have one microscope, Lumera 700, Centurion fake machine, and 2 operating tables. The operating table is one of the most important item in the operating theater. This is a chair. Patient walks in and sit and recline like this. I always approach from the temporal side of the patient. I can get enough space under my table in this chair. The head position can be easily adjusted by the foot pedal. So before starting surgery, it is first important point to get a flat horizontal head position so that we can get a good reflex. Good reflex make the surgery quite easier. I prepare everything before starting surgery. If I operate 60 cases, I prepare 60 visco, 60 Provisc, and 60 gloves and drapes before starting surgery. When start each case, my scrub nurse will prepare the lens. The lens is set into the cartridge. My incision size is about 2 millimeter, or sometimes sub 2 millimeter, small incision. So I prefer to use this D cartridge rather than the disposable injectors. The lens is set curling downwards. Because the plunger always moves, touching on the cartridge floor. So proper setting of the lens into the cartridge is important. If the lens is set curling downwards, the plunger will properly push the lens forward. For preparation of the patient, I use this pre-cut drape. It's quite easy and quick to drape the patient. The slit is pre-cut in the plastic part of the drape, so upper and lower lid can be easily covered by this drape. 1 week before surgery, I give the patient antibiotic eye drops to prevent the endophthalmitis, and also this draping is a very important point to prevent the infection, because by this draping, the meibomian secretion can be perfectly protected. You will see the upper and lower lid is completely covered by the drape. So meibomian secretion is completely blocked. More than 40% of my cases are toric. I mark the reference mark at 3 and 9 o'clock position using an electric toric marker or just the slit lamp. During the surgery, I use this intraoperative toric markers. I mark the final axis, and also the capsulorhexis size is marked on the cornea. If you implant 6 millimeter optic lens, the ideal size of the capsulorhexis should be 5.5. You will clearly see the 5.5 mark on the rhexis. For the incision, I prefer to use a diamond blade. It is a 100 micron, very thin blade. It is very sharp, and the incision is very clear. So it is easy to seal at the end of the surgery. This is a trapezoid blade. At the shoulder, it is 1.7 or 2. So according to the depth of insertion, you can control the incision size. I approach from the temporal side of the patient, and this is a side port blade, 0.6. I like to make a small side port incision because during the implantation of the lens, I need to keep the high intraocular pressure. If the side port incision is larger, there's a leakage of OVD, and I cannot keep the high pressure. In this case, the incision size was 1.9. I use an Utrata capsulorhexis forceps. It's a special forceps with a very, very fine blades. Intercameral anesthesia is applied preservative-free 0.5% lidocaine, and the anterior chamber is filled with Viscoat. Keep high pressure with Viscoat, and this Utrata capsulorhexis forceps is used to make a capsulorhexis 5.5. You can follow the mark on the cornea, so you can make it, always you can make the constant size and the position of the capsulorhexis at the appropriate position. Hydrodissection is one of the most important points. I use this bent 27 gauge cannula. The tip is tapered a little bit. And the most important point is this cannula should be attached to a small syringe. You should not use a big syringe. I always use a 2.5 small syringe. Cannula is introduced horizontally and inject small amount of VSS, and you can easily rotate, perform the cortical cleaving hydrodissection. Before performing the phaco, I always pre-chop the nucleus. For a myopic patient, I use a long sustainer. For the soft cataract, I always use a combo pre-chopper by the karate technique. But the nucleus is harder. I always support the nucleus with the second instrument to reduce the stress on the ciliary zonules and the capsular bag. Supporting the nucleus, we can reduce the stress on the zonules. Once the nucleus is pre-chopped, following phacoemulsification is quite easy. This is a harmonics phaco tip, square off-center tip. I always use in a burst mode. Mainly I use in a vacuum to remove the cataract, and only when the tip is occluded, I use a very small amount of the ultrasound NH just for the purpose of clearing the tip. So you'll see the small number of the NH. For IA, this is a curved IA tip. The tip is rounded, and the aspiration port is drilled 45 degrees toward its aspiration port. So you can also safely vacuum the posterior capsule, and even the subincisional cortex can be easily removed using this IA tip. So in myopic case and multifocal cases, or of course in the cases with weak ciliary zonules, I use a lot of capsular tension ring to stabilize the capsular bag. This is a universal forceps I use to implant the CTR, and this forceps can be also used to suturing the tenor nylon, or you can use this forceps to use an iris retractors. So implantation of the lens through this 1.9 incision, you need a counter force. Providing a counter force by the nucleus sustainer, the lens can go through this small incision. For the toric lens, I hold the periphery of the lens with the nucleus sustainer and carefully remove the proboscis in the anterior chamber. And then at the final stage of the surgery, I will polish the posterior capsule. Nowadays, I prefer to use this straight capsule polishers. I will introduce the polisher under the intraocular lens, and the fine cortical fibers can be cleanly, easily removed, and residual debris will be aspirated. Then same hydrodissection cannula is used to seal the incision. The ultrasound NH is very small. The incision can be quite easily sealed. And the toric lens is set to its ideal axis. This is a normal step of my cataract surgery. Thank you very much for your attention.